Okay, glad to have everybody with me today. And we're going to talk a little bit about the vaccinations, obviously. So there are some things that I go through at the beginning of all my talks. You may remember about disclaimers, things that I did not say, you did not hear what I thought I said, all those kind of things. And that's because I just want to always make sure exactly what is true, not true, and trying to give everybody the best guidance I can for that. Next, people that I work with, people I owe a thanks to, includes a lot of my co-editors for the different books. Also, these are three of my boys who I owe a lot of thanks to, and that's why I worked so hard all these years, like all of us, for our kids. These are the books that I've written for the American Medical Association. Because I often have some physicians on the call, I always have to give the disclosures because that's a financial conflict of interest and somebody has to be made aware of that. This is the causation book, the return to work book. This is the internal medicine 6th edition book. This is the book on disability benefit systems. Just if you have problems sleeping and I haven't helped you enough, buy one of my books, that'll put you to sleep for sure. If you're looking for some of the references for the information that I'm providing, there are different references that have now been published. We are working on the next edition of the coronavirus guideline that should be out in the next week or two. That'll be our 7th edition, should be coming out. The most recent one is December 14th. Those are available in front, meaning that you do not have to have a subscription to any service to be able to view the guidelines. So these are the articles that were also published for the state of Tennessee, because they have an 8-state consortium that talks about how to look at survivors of COVID-19 and how to evaluate them. There's also ones that are in the AMA Guides newsletter and also the Journal of Occupational Environmental Medicine. Those are all available online. You don't need a subscription for those things and can help you out in that regard. Okay, so what I'm going to do is I'm going to walk you through a few different areas to consider for this condition. The first is we're going to do a brief history, then we're going to talk about testing, and then we're going to talk about the current experience, because this one is really focused on what are the current adverse possibilities. Remember, the title of the talk was the potential difficulties with these vaccines. Okay, so brief history. Just to remind you, the difference between epidemic and pandemic, right? The epidemic is more of a localized experience, where the pandemic goes across different countries. And so you may have heard of Ebola. That's a classic epidemic, whereas the pandemics in the past, people do talk about the old Spanish flu. And that is also something that has been useful in discussing some of the aspects of immunity that are going to be coming up in this current problem. When you're talking about immunity, you're talking about what's going on primarily in the blood testing, right? So what do you do to test blood? You look for the antibodies, right? The antibodies are those proteins that attack part of the virus. So the most common one that everybody's heard about is the spike protein. That's the one that most of the antibody tests are geared towards. That's the one that the vaccines are geared towards. And what we know is that those antibodies usually start appearing at 4 to 6 days after an infection. The IgM, the first one, peaks around day 12 and then starts dropping off. IgG is the longer one. It takes a little longer to show up, but lasts a long time. We know from the original SARS outbreak in 2003, the IgG lasted at least 2 years. We know from the MERS outbreak in 2012, MERS is a closely related cousin to the SARS, that IgG lasted at least 3 years. So what we are expecting is that if you have the real infection, that you're going to have protection for quite a number of years. If you get the vaccine, you're probably going to have protection for quite a number of years. It is true that people who had less symptoms had lower antibody levels. And it is true that if somebody drops it, they say, well, can't I get reinfected? Even if you were to possibly get some level of infection, it usually does not cause any illness, and it usually disappears quickly, right? We know for sure right now that the regular antibodies that you get are going to last for at least 10 months, and that's ongoing, obviously, as we get further and further and further into this condition, right? There's some studies, so I don't want to bore you with all this stuff, but this is some of the boring stuff, so just so you've heard it once, but this is the studies that take a look at some of the different ways of measuring the antibody levels over time, right? This one gets a little bit busy here, so just stay with me on this. Stay with me. I know it's a little tight on there, but this is looking at the different measures of the antibodies over time and how they all go up and then they slowly decline over time, right? And that's one of the ones that you see when you're using vaccination, right? That's one of the ways that they can use vaccination information to judges, okay? So I want to emphasize a very important concept, okay? Now, don't go crazy with me on this, right? Don't say, oh my God, what is this stuff, right? So this is a very important piece of immunology that I just want to summarize for you because I think it helps explain a lot of information, right? First of all, we all have in our bodies macrophages, right? And all you need to know is they're the ones that say, hey, wait a minute, this antigen, this virus doesn't look normal. And I'm going to start sending out little messages to the T cells. Those T cells say, oh, this is new stuff. We better start fighting this, right? So it starts developing different ways to stimulate other cells. One's called a T helper cell and a killer cell. It also stimulates the B cells, right? So the B cells are the one that makes antibodies. But look carefully. You're seeing here two different paths. One to the antibodies, but the other to cells. So that's why we say we have two different immune responses. One is the antibodies and one is the cells. Why is that important? That's important because not all antibodies measure immunity. That's only one measure of immunity. The other measures are these cells, which can be around for a very long time, usually lifetime, right? So let's take a look. Just one study, this is out of San Diego, that I thought was very important, right? When they did formal testing of all the cells and the antibodies, even patients with mild disease, 100% had T cell response and 100% had the IgG antibody response, right? 100%. This is normal. This is exactly what we see in all infections. Now, watch this very carefully. Patients who never had exposure to COVID-19, 50% of their T cells showed activity. What does that mean? This institute had blood samples from 2015 to 2018 before COVID-19 ever existed. And these people, 50% of them still showed that their cells had reactivity to it. You say, how's that possible? It's possible because coronavirus has been around forever. It's possible because 4 of the coronaviruses cause the common cold. Statistically, you and I already had coronavirus before this thing ever happened, right? And so that is why you're going to have these long-term responses, which by the way, this is an important piece about when people are focusing on the antibodies only and not taking into account that there is this cellular protection that we all have, right? And so we know this from human studies, from monkey studies, and from a lot of other systems. We know this from a lot of other viruses, not just this virus, right? So it's not just antibodies. They're important. It's one of the things we vaccinate for. It's one of the things we measure, but don't forget what's operating there. It's not just antibodies that are operating. It's those cellular immune responses, right? So when you try to look this on a graph, so let's look at this together, right? Here comes the SARS-CoV infection, right? And then all of a sudden, you start having the ability of the virus to replicate. And if you knew that somebody was going to have this particular infection, if you knew that that was going on, what you'd see is that slowly the virus starts replicating, right? What you'd also see is that you might be able to retrieve it if you're doing studies on somebody. But all of a sudden, you get near symptom time when somebody says, uh-oh, I'm not feeling well. And look at the level of virus already. It's very high. A day before symptoms, 1 to 2 days after, and then the virus level starts dropping off, right? And what you do see is that now your PCR test is going to be positive for sure, and then the antibodies start showing up later. But notice how that IgG goes out for a very long time. right? And so that's the time frames to think about. Another way to look at it, here's another graph. So look at this one. Look, really important, because I want to emphasize the difference between these, right? You've got up here the T cells. Now notice, you're 2 weeks after infection, they start peaking out, and then they drop off, but they go on a very long time, right? Look at what happens with the B cells, the antibodies, the IgG. They go up and they start dropping off. But what ends up happening is that these cells last a very long time. I'm going to show you how long. There have now been studies done. Ready for this? Listen to this very carefully. There was the influenza pandemic of 1918. There are some people that they found who were little kids at that time, and they're still alive today, and they went and tested their cells, and they still showed response to the influenza decades later, right? That tells you how long and how durable these protections can be. Is it possible that somebody could get an infection with a new strain? Yes, anything's possible, right? Is it possible that that new strain could make somebody even a little sicker? Yes, that's possible. But when you look in the literature, you're talking about maybe 4 case reports out of 30 million infections worldwide. It's almost impossible, right? So anything's possible. What is far more medically probable, what you have to focus on is, if you have the infection, get the vaccine. If you haven't had the infection, get the vaccine. And when you have that vaccine, you are going to have benefits, and society's going to have benefits, right? Okay, that's a rest stop. Okay, get the cracks in there. So let's talk about some of the vaccines. Okay, here we go. So vaccines. We know about the vaccines that have been tried in many conditions without success. HIV, remember they used to call it AIDS? Hepatitis C, we still don't have a vaccine for that. Some of these are tough to get. We do studies in monkeys, right? You do studies looking for neutralizing antibodies. You look for safety signals and you try to figure out, is it possible, okay? But one of the things I want you to understand, this is very important, watch. You have to understand, a vaccine will prevent disease. If you even get sick, generally be very mild at most. But it doesn't mean you won't be quote unquote infected. It doesn't mean that you can't have a new virus that comes onto you and the virus kind of tries to set up shop. So you're technically infected. And it's technically true that you could also have a scenario where even if you're infected, it's causing a little bit of virus to shed from you, right? This is true for all viruses. But you have to understand, if you're not coughing, hacking, sneezing, right, your odds of being able to transmit this go down extremely low, because you have to have a certain volume of virus, a certain way of expelling it, a certain propagation. And if you're not that ill or ill at all, then what you're getting is a little bit of virus in you, but almost impossible to transmit it, right? Also want you to remember something. In the vaccine production literature, right, about 93% of vaccines never make it to market, right? The usual time frame, 5 to 10 years, and the safety has always been an issue, but the FDA is watching it. But in particular, that's the procurement's benefit of the Operation Warp Speed from the prior administration, which was really one of the medical accomplishments, almost miracles, that doesn't get talked enough about, although it does more in the medical literature, where we're so impressed by that turnaround and that ability of that turnaround to bring us some of these benefits, right? Okay, now, a vaccine that we have right now, which includes Pfizer, Moderna, and now Johnson & Johnson, they should work on all the variants, because you've heard about all this, oh, what about the variants? All the data right now, it looks very good that it would also cover the variants, okay? They're also formulating some right now, mRNA vaccines that would incorporate and include this. Now, why is that possible? Well, how is that possible if there's this variant? Okay, first of all, you have to remember, all viruses mutate. That's what they do. They do it all the time. And so that's exactly what's going to happen with all viruses over time, and same with coronavirus. But most mutations are very subtle, minor little things that don't make a big difference, certainly not with vaccines, certainly not with your immunity. Number two, those changes are almost always right now in the spike protein, the one that the vaccine is geared towards. But the vaccines are geared towards about 20 different sites on the spike protein, not just one little site. So you can imagine that there's a mutation and it alters part of the spike protein. It's not going to alter all of it. So you're still going to be able to have a vaccine that goes after this and helps you try to understand what's going on there. And so that's why I keep saying, if you had this infection, take the vaccine. You can always get those extra spots of the spike protein, always boost your immune system even further to try to help you with that, right? And that's going to be very helpful. Okay, this is a busy slide. I don't want to bore you to tears with this one, but this just shows about some of the different companies. So we know about the AstraZeneca, the Pfizer, the Sinovac, Sinopharm, and I just want to show you a different little chart on this one, right? This is the one that looks at some of these different ones that you may have heard about, right? So Moderna, Pfizer, Johnson & Johnson, which just got released. The AstraZeneca should be coming out. The Novavax, right? The CureVax and some of the Chinese products, right? And they talk about how it's made, right? What dosages we use, right? And what's coming up right now, very important, very important. Stay with me on this. You may have heard that Moderna and Pfizer required that extremely negative cold chain storage. Recent literature says probably doesn't have to be that cold. Also, the new one, Johnson & Johnson and some of the others, will not require that level of freezing. Can be usual refrigeration transportation. Well, that's the shots I've always been given in the office. As you know, I'm a designated center for the CDC, and so there's always a chance that we might even get some of this into the regular doctor's offices soon, and this would be easy to administer. By the way, Johnson & Johnson uses that same type of method that we're used to. It's not the mRNA methods. Nothing wrong with the mRNA, they're new, but you're using some of the older methods, right? So what are those? What are those types? Okay, so there's 4 types of vaccines, 4 types, right? Here we go. The inactivated. That's where you put a virus in culture, then you inactivate it, right? So we know about these. Hepatitis A, flu shot, polio, rabies, MMR. You've seen those before. You've had some of them, right? The ones that are currently along that line are the 2 from China, the Sinopharm and the Sinovac, right? Number 2, recombinant proteins. These are also called subunit vaccines, okay? This is a protein that's produced in a cell culture. We have examples of that, right? Hepatitis B, pertussis, the tetanus shot, the pneumonia shots, right? That's what we use for that, right? The viral vectors, right? The viral vectors are ones that kind of hitch a ride on something else. So this is the ones that have been tough to work on with HIV, TB, and malaria, but that's the ones that Johnson & Johnson and AstraZeneca were able to work out. So now we have Johnson & Johnson being able to use this. So what you do is you take a virus that looks like one of the typical SARS coronaviruses, but the difference is this one can't replicate very well. So what we do is you kind of attach it to another virus, get inside the body, let it kind of replicate with that other virus so that you see the proteins, your body develops that immune response, but you don't have real virus, right? Last one, the mRNAs, okay? So this is the one that everybody talks about. This is also called nucleic acid vaccines, right? And this is where you take some actual genetic material, you put a fat around it, a lipid. That allows it to be protected so the body doesn't break it down. That lipid allows it to attach into our cells, and then the cells start producing just the spike protein, right? And so those spike proteins come out of the cells, and the body says, this does not look normal, and starts developing the antibodies against it, right? Now, how do you know what to expect, right? So in the US, there are 4 systems that are monitoring for trouble, okay? 4 systems in the United States that monitor for adverse outcomes, okay? So let's go through those 4 systems, just so you've heard about them, just so you know how the safety signaling is going on. What are people looking for? What are they doing? Okay, 4 systems, here we go. First one, vSafe. This is one that you can do with your cell phone. And when you go to get your shot, you were probably offered, would you like to help participate with the CDC on this particular mechanism of looking for side effects? what happens is you sign up, right? And then you get a text message to check in with the CDC. They want to say, how you doing? What are you feeling? And then you send your message to the CDC. If all of a sudden you start saying, yeah, I had to go see a doctor about something, I had to be hospitalized for something, or I've had a big problem, this gets forwarded to a call center. And one of the VAERS people will call you and say, what happened? When did it happen? What did you show up with? What were your symptoms? What did the doctor say? That's one of the ways that it's going to screen to see if there's any adverse outcomes, okay? And what we see so far. Okay, here you go. Here's the summary from vSafe, right? So look, people receiving one or more doses in the United States, Pfizer, Moderna, all the vaccines. Okay, so this data is as of, about almost about a month ago, because most recent data I could find. Now, notice about 10% of people in the United States who were given a vaccine and said, do you want to sign up for vSafe? About 10% of the people did it, right? And so that's where you're getting that data. About 2 million people check in with the CDC. That number is growing, okay? Also, I want you to notice one other thing here, very important. In the vSafe, it turned out that there's about 15,000 pregnant women that got the vaccine. This is critically important. Why? Because in the studies, pregnant women were not in the study groups. So you had no idea about, is it really safe for a young lady? So folks have heard me say that I'm a big proponent of the vaccines. There's a couple populations I'm giving a little bit of a hold off, a little bit of hesitation, a little bit of let's wait and see. That would be the kids. None of the studies were done on kids anyways. And the vast majority of kids who get this, it's very mild, so it's a non-issue. So that's people under 16. And my young ladies who might be married, thinking of starting a family, those kind of folks, that's a conversation we have to have, right? Next, what does it show? What do all those people texting back say? Well, here's the data, right? And it looks like about the same between the two vaccines. Pain, fatigue, headaches, muscle aches, chills, nausea. And it is true that everybody's talked about when you get that second dose. Look over here, look at that second dose, right? You get a little bit more reactivity. So a lot of patients will say that. They'll say, look, I took the first shot, wasn't so bad, but the second shot kind of walloped me more. That's true. That's what you see in the data, right? That's, in my world, in the medical world, a good thing, because it means your body recognizes this as foreign and that you're going to have a good outcome because your body really saw this and produced those proteins, okay? Number two, second method of evaluating patients for vaccine safety, VAERS. The CDC and the FDA together, right? And this is a system that is used by people to report problems. Now, let's go through this. The strengths. It's nationally based. It rapidly can detect a possible safety signal issue. It can detect rare events, and it's available to the public, okay? Bias, problems, limitations, right? So what happens is VAERS is like this open-ended thing, which is anybody can go to VAERS and say, I took this vaccine, I had this problem, and that's it. There's no mechanism in the VAERS system to have somebody that calls you and goes through your medical history. There's no system that looks at the VAERS and says, oh, well, that's a true reaction versus somebody just happened to be sick or somebody happened to have a reaction, but it's not really due to the vaccine. So what this does is it's a big shotgun, a big listing. But you could imagine that if a lot of people all start saying the same thing, it'll show up on VAERS and people will start saying, oh, maybe there's something here. Number two, if there's rare stuff, it also could show up on here because there's a lot of people. So what do you see? Okay, let's take a look. So when you look at Moderna, Pfizer, right? There's non-serious adverse events, serious adverse events. How old were the folks? And what percent females? So this is much more common in females, right? About 90% were not serious. So that's 372 reports per million doses administered, right? So if every million shots, right, on average, they got about 372 reports. Okay, how about the serious ones? Okay, so serious is defined: death, hospitalization, life-threatening, permanently disabled, some kind of congenital anomaly that developed in someone. If you see any of that, that's much more serious. There are about 45 reports per million dosages, right? In the medical world, that's considered small, right? Other reports to VAERS. You see the same things again about the headaches, right? The fatigue, the chills, right? And so in this particular sampling from VAERS, this is similar to the clinical trials, less than you saw in VSafe, right? So why is that? Well, it all depends. Who's willing to do VAERS? Who's willing to do VSafe? How good are people reporting? How often do they report, right? How much is this verified? So they can change, right? That's why the data can change, right? Okay, number three, third mechanism to look for safety in the United States, CISA, right? That's the Clinical Immunization Safety Assessment Project, okay? So what this is it uses 7 medical centers that are very actively involved in vaccine research. So what these people are doing is they have departments that are taking information from care providers, local communities, medical reports. They are actually going through and looking at different information. There can be people who call the CDC and say, I am having a problem, right? I can't get a straight answer from my doctor. I'm not sure what to do, right? They'll say, well, you can call one of these centers and they'll call you. You can fill out a form. They can help you in trying to understand what's going on with your symptoms or your possible reaction, right? So CISA has responded to 143 clinical inquiries, right? So this is where somebody goes to the CDC says, yes, we think that this does require some kind of follow-up or looking at it, and then it starts to give additional data to state departments of health, the CDC, the manufacturers, about what might be going on, what might be some possible mechanisms for this, what should be thought about for the next study on these vaccines to look and see whether or not it's reasonable or possible that it could be related to the vaccine, okay? Number 4, last one. The number 4 mechanism for looking for safety in the United States, called the VSD, Vaccine Safety Data Link. I want you to look at this. This is very robust, okay? This is where they have these 9 centers that have integrated everything they can find on you. They're looking at your birth and death certificate information, family linkage information, procedure codes of things that have gone on with you, any hospital records, emergency room visits, outpatient visits, immunization records, all your demographics. This is all linked together into one big pile, right? And you can imagine that that provides a lot of data about you, right? So it can get very specific and has a lot of people in it, right? So right now they've got about 12 million people on this, and they're able to start looking at, okay, who's gotten the dosages, right? First dose, second dose, right? How old were they, right? It starts giving very specific data about what are we looking for in this group, right? And when you do that study, you start to see some of these types of analysis, right? You have to look at this chart carefully. Why? Because when people start talking about side effects, right, people are not being made aware that there's a lot of these same conditions that you've heard about. I heard that you can get brain problems, heart problems, lung problems, seizure problems, right? Inflammation of the heart, all these things, right? Yes, but in the same group of people who never had the vaccine, you can also get that, right? So when you compare these two, right, you are more likely in this data set where they really look at people in high levels of detail, where they have everything about you, all your medical history, all your medical information, everything linked together, you are more likely to get some of these conditions if you're unvaccinated, right? So look here, look. events in vaccinated people versus events in unvaccinated people. See the difference there? So the reason this is important is you're going to see things in the web. You're going to hear stories. Oh my God, I heard you get this and this and this and this. First of all, you know, a lot of those things can happen just as regular medical conditions, unfortunately. Number two, in this data set where they look at this very carefully, you're much more likely to have problems if you're not vaccinated than if you are. And part of this is because some of these unvaccinated people had the real infection and got some of those complications from the coronavirus infection. Some got it from other conditions, right? But if you're vaccinated, you're not likely to get it. So this tells you that the safety signaling is very good for these types of vaccines, right? Okay, now, anaphylaxis, right? So people may have heard about the allergic reaction, right? And there is a lot of work that's been done in this area. There was just a study I was looking at recently that was summarizing some of this data, right, about people who get the shot. So in general, if you are going to get an anaphylactic reaction, it is way more likely that you are a highly allergic person, that you have had allergy shots, that you've had a history of anaphylaxis, that you've always had to carry an EpiPen. Those are the people that are a little bit at risk for this. And again, that's not everybody, right? And when you look at the characteristics, who gets the anaphylaxis, right? So what's the average age, right? So again, you saw it a little more commonly in the Pfizer product than Moderna. People are not sure that makes a big difference. Much more common in women than men by far, right? The minutes to symptom onset, so you see it's about 10 minutes, right? So that's why facilities will say, look, if you can hang around for 15 minutes after you've had your shot, just to make sure, or somebody say, come sit in the office for 15 minutes. That's why they're doing that, because if somebody were to develop those particular problems, then you want to give them an EpiPen, give them a shot right away, and try to help mitigate real quickly that particular type of reaction. Confirmed case of anaphylaxis versus time of onset. So you can see the vast majority early on. Can you have these people that are unusual, that go out for a period of time? Yes, anything is possible, right? But by far, the vast majority of these are going to be within 10 to 15 minutes. That's why you usually hear that. But if you feel like, okay, I'm a little bit more at risk, Mark, I'm a little bit more of an allergic type person, fine. Then you would be the kind of person to say, look, then just take something to read and sit there for an hour, right? And don't think about it twice. Don't let it get inside your head that there's not medical care immediately available to you, right? Now, we talked about that and looking at the cases, right? So when you look at this, they'll give you a rate that says, okay, 5 out of a million get this. Yes. But that's because this was early on and included certain study groups, right? But as more and more doses are being administered, these rates are dropping, right? And so just for example, back in December, the rates used to be 11 for Pfizer and 2.5 for Moderna. But look, you can already see it's dropped further, right? That's the nature of immunizations. That's the nature of studies. The longer you go, the more N you get, the more number of people, the more certain you are. You start looking at those rates and realize how very uncommon these things are, right? And death. Okay, reports of death to VAERS. Okay, so remember we talked about this. VAERS is that big wastebasket where anybody can give a report and anything can be said, but you don't really have very good documentation of if it's true or not, right? Because you don't have that robust data of doctors and codes and visits to make sure that you know what's going on there, right? But nonetheless, if you look at the VAERS, the median age for death was right near 80. The reason I pull out that number is because with coronavirus infection, the median age for death is 80, right? And then when you start looking at the ages, right? How many people were under age 65? Okay, see that number right there? Again, very interesting here that now the deaths, no difference between men and women, but we saw earlier there's a problem. The vast majority, again, the long-term care residents, right? That was always the case with this coronavirus infection, always why there was a problem with the nursing homes, because of that tendency to have the elderly really bear the brunt of reactions to these medications, right? Okay, some odds and ends. Cold storage may be modified. We talked about that. The J&J Astra is the old way vaccine. J&J is the one dose. Again, that got released. Trying as much as I can to get a hold of any of these things, but this is so heavily government controlled right now, hard to do that. The pregnancy, my young female patients, I've said it's a little worth watching. Only one dose may be coming. Certainly in the mRNA vaccines, you get a very nice 75-80% response. In the Johnson & Johnson, you probably get a good 75% response. And so this may be what we see in the future of not even necessarily needing 2 shots. But in general, you should get the shot. You can wait after infection to the immunity. That's true. And they do say, okay, make sure you clear it for, depends who you talk to, 60 days or whatever like that. But no question, I think that you should get it once you're symptom free, right? There's greater than 30 million doses now and counting. The Operation Warp Speed, we talked about that, was a remarkable program. This is intense and comprehensive safety monitoring. I have to say, and I said before, that we weren't going to have the same safety signaling development. That's true. But in reverse, we've actually had double down efforts at safety monitoring since they've been released. Also, the safety monitoring we do have says, you know what? This is working, right? That the safety looks like it was in the trials, right? And there does not appear to be any safety signal that's a concern for death. This is very, very unlikely, way more likely that you would die from the real infection or have severe complications from the real infection. Okay, so that's the end of the talk. And what I'm going to do is I'm going to be